I'd like to thank Dr. Mallika and the organizers for giving me an opportunity in this instruction course, and Dr. Lalit Verma has made my job easier by discussing about the vitreous loss and a little bit about how to manage if there is a nucleus drop. I would like to also acknowledge my friend Dr. Rajiv Reddy and also Dr. Mallika Goyal for this presentation slide. So there may be many predisposing factors for nucleus drop, such as novice surgeon. Initially, the chances of complications are higher. As you become more experienced, the complication rates reduce. In fact, a lot of surgeons are there who have not had nucleus drop in many years, many hundreds and thousands of surgeries. So it's not a routine occurrence if you are a good surgeon, and that good surgeon is not because of your hands alone. It is because of your planning also, how you assess your patients preoperatively. So there are many conditions of the eye itself which can predispose to higher risk of nucleus drop, which includes hard cataracts, complicated cataracts because of either uveitis or any other condition. Post-VR surgery are always a great risk because after vitrectomy, many patients develop cataract, and we refer to our VR surgeons, and they have inherently a higher risk of nucleus drop. So if there is a VR surgeon who is not with a cataract surgeon, and then you refer it to another setup for cataract surgery, then again it can come back to you as a VR surgeon that, after nucleus drop, you have to again manage the patient. Then small pupil, posterior polar cataract, and pseudo exposure. These are the other common reasons for as risk factors for nucleus drop. As I had mentioned briefly in the management, that the most important thing is never panic. That's the last thing for any surgeon under any situation, because every situation has an answer provided your brain starts thinking at that time. If you cannot think as to what is happening and what needs to be done, you will end up with bad outcomes when actually you could have had good outcomes. And Dr. Lalit Verma showed very excellent videos of what we should not do if there is a vitreous loss, and also if there is a nucleus drop, how not to do that. Ego has no place, and if there is any problem, you can always tell the patient that this problem happened. I think it's best in this situation and in your best interest that a second surgery will be required, but don't worry, we will take care. So if this attitude is there, that it's not that I have to place the lens and remove the nucleus from the vitreous and retina, come what may, then you are likely to have bad outcomes, and those bad outcomes will lead to problems to you, not the vitreous loss or the nucleus drop. Vitreous loss, nucleus drop can have 20/20 6/6 vision after 2 weeks. Patient will be happy. But if your ego comes in between and you say, I will put the IOL come what may, there is a nucleus inside, there is an IOL also has dropped inside, patient has a retinal detachment, and then after 1 month patient is just PLPR. So imagine what you want. You want your ego to be satisfied on the table that I want to tell the patient that, I have put the lens, everything is fine, just some problem is there. Or do you want 6/6 vision for the patient? I think the second option is better, because that patient, even though there was some delay in the recovery, patient will still be happy. So ego has no place. Apart from that, good management skills are required, and Dr. Lalit Verma has already shown great videos of how to do a good vitrectomy. Anterior vitrectomy is one of the most important things in this condition. Don't just close the wound and put an IOL and send to a VR surgeon. Cortex removal makes the job easy for a VR surgeon. And IOL placement is possible in most cases of nucleus drop. So unless sometimes you have IOL drops, whether it's foldable, non-foldable, it's easier to remove through the pupil in many cases. In nucleus drop, the big advantage as a cataract surgeon is that even if there is a nucleus drop, in most cases you will be able to put an IOL. There is no contraindication. Whether it is in the sulcus, most of the time it will be in the sulcus only. But please make sure that you put a large optic, preferably 3-piece, so that we don't have to worry about IOL dislocation at the time of the vitreoretinal surgery. So, and I also put sutures in these cases, because wound leak may happen during VR surgery, a lot of manipulation can happen. What about the timing? If you are in the same theater complex, if there is a nucleus drop, ideally yes, you can call the VR surgeon if they are free or available at that time. But remember that same day surgery is not a necessity, it is not a must. you can have excellent outcomes in the second surgery also. Yeah, it's always good that you feel better in one surgery, the patient could go back, that you didn't have to call the patient for second surgery, the patient was not inconvenienced, you are not inconvenienced. But if there is a surgeon is not available for whatever reason, second surgery at an appropriate time, which is not the next day, which is not the third day, whenever the availability is there and the IOP is under control, cornea has cleared, that is the time that you have to take these patients up for surgery. What can nucleus do inside the eye? It can at the most cause inflammation. And inflammation, we all know, has treatment in ophthalmology. It is not something like endophthalmitis that you have to rush immediately. Inflammation we have been treating day in and day out as ophthalmologists, whether it is uveitis or due to any other cause. So we have excellent treatments for inflammation, so you don't have to worry about same day surgery. And the most critical part to prevent nucleus drops is management of risk by planning. Don't treat patients like cataract surgery in an assembly line like a car production manufacturing facility. You have to examine the patient and make individual decisions for that particular eye, that particular cataract. Do a meticulous slit lamp examination and talk to the patient to assess their risk factors. And you have to look at whether there is small pupil. If there is small pupil, you have to plan. Don't say, oh, this patient has small pupil at the time of surgery, and say, oh, okay, I have not planned, so I start doing phaco, and then you end up with complications. Assess the patient preoperatively, write down notes. So write down notes somewhere, or even at least before the surgery, if you are going to check that, okay, I have to have iris hooks for this patient, or an intracameral adrenaline for this patient. Just minimize your risks, make yourself comfortable. It's not just about the patient. You also have to be comfortable doing the surgery. Same way, if there is any subluxation, do you want to carry on with the phaco? If there is a very hard nucleus, grade 4, do you want to carry on with phaco? If you are not a very experienced surgeon with very hard nucleus, you will always have the option of SICS. So these are the kind of planning which you have to make pre-operatively to minimize your risks. So now I'll show just one video of a nucleus drop. This is a case where a nucleus drop happened by a cataract surgeon in a separate facility, so cataract retina surgery could not be done immediately, but as you can see, well sutured. This is an SICS wound, very well sutured. There's no ego about stitchless surgery in this. Yes, we had a problem, we have to manage it. And here the superior iris is kind of incarcerated in the wound. We are trying to remove it with the iris repositor, but you can see that there is no vitreous in that. They have done already a good vitrectomy in this case. And as a surgeon, a few tips for VR surgeons is that do a good vitrectomy, not just core vitrectomy, even the periphery has to be, a good vitrectomy has to be done, because before inserting fragmentome for these patients, this is a hard nucleus, it is important that you do a good vitrectomy. Never rush in to use a fragmentome with vitreous all around, because you are likely to create retinal breaks invariably and then cause retinal detachment, and then you have to put oil and then unnecessary complications. Do a good vitrectomy before you use a fragmentome. Very soft nuclei you can do with a vitrectomy itself, but in hard nucleus, whenever there is a doubt whether it will be possible with the vitrectomy, keep a fragmentome ready. Don't use ultrasound of the fragmentome near the retina. You elevate it, bring it to the mid-vitreous, and the last few portions of epinucleus and cortex you can always remove with the cutter. You will have some pieces here and there. Never use fragmentome for epinucleus and cortex near the... And then the final step is the meticulous peripheral dissection, peripheral depression. So peripheral depression is very important. You may have done a very good vitrectomy, nucleus removed, IOL has been placed, but ultimately you missed the retinal break, and post-operative patient develops a retinal detachment. So these are problems we should avoid, and never take shortcuts or take a shortcut approach to all patients as the same basket. So you have to plan for each patient separately. So I think this is a manageable condition with excellent outcomes. It is us as surgeons who have to take care of these problems, and the outcomes are automatically fantastic in these cases. Thank you very much for your kind attention.